little bit on treatment. I have some of that embedded into the deck, but I know we're going to spend a good chunk of the time today on the actual workflow and what that looks like. So without further ado, because I know we were a bit delayed getting started, if you want to go to the next slide. Perfect. So we'll talk a bit today about, and some of these objectives again may change just because we did modify these slides recently to incorporate the newest workflow. But we'll talk about some barriers and techniques for engaging families in treatment. I'll very briefly touch on executive function. I think this group is well aware already. Again, briefly touching on CBT, and we'll discuss some effective accommodations. But main objective here today is to discuss the newest workflow. So we'll go to the next slide. Perfect. Okay, you can skip through that. It's basically the same. Okay, so this is my buddy, Dr. Ned Hallowell. If you don't know him, I talk about him like I know him personally. I've just read his books and attended his seminars, but he is sort of the godfather of ADHD, if you will. He's written several books on the topic. Literally wrote the book on ADHD. His newest book is ADHD 2.0 and has a ton of updates now that we know more. But I love his philosophy and his perspective, and so I included a quote from him here. He says that treatment includes education to ensure that the child and parent understand this is not a deficit disorder, but a condition that can be associated with tremendous success. And I'll pause there for a minute because I think so often that is overlooked. The diagnosis has the word disorder in the title, and so I think that often the word we sort of hyperfixate on the fact that this is a disorder, it's labeled as a disability, and all of these things are true. But the inverse is also that when harnessed appropriately, this is actually a neurodiversity that has been shown to encourage success in individuals when they are equipped with the proper skill set. And I think when we see a patient or a family with a new diagnosis, or even they've had a diagnosis for a long time, if they've been approached by such a deficit lens, it's hard for them to see the beauty and the positivity that can come from an ADHD diagnosis. And so I love that Dr. Hallowell talks about this. He says the real disabilities are the shame, fear, and believing you are a loser. And that really is impactful, I think, when I hear that, because so often these kids, before they're diagnosed or treated, that is the message that they're hearing in school, in social environments, and most importantly, and unfortunately, internally, because they are most of the time fairly aware of the difference, and wondering why they're different than their peers, why they can't seem to get their work turned in on time like everyone else. And there's some shame that comes that is associated with that. And as well as this fear of the unknown and of their future success and the uncertainty there. So another thing that Dr. Hollowell says is that it's not a deficit of attention, but rather a wandering of attention, not a disorder, but rather a trait. If you manage it properly, it can turn you into a phenomenal success. And if you don't, it can ruin your life, which makes it unique and fascinating. If you don't, I know some people in the chat are already commenting about Dr. Hallowell. Love that. Please check out his literature, his books. He's fantastic. Next slide. Thank you. So Dr. Hollowell also says, he says ADHD needs a better name. And I love that. So some experts say that ADHD would be better labeled as either executive function deficit disorder or variable attention stimulus trait. And I definitely lean towards the second because, again, it takes the word disorder out of it, and really is what it is, right? It's a variation of attention, and impacted by external and internal stimuli, and is a trait, and something that we can learn to harness those traits and use them for good. So next slide, please. Okay, so talking through what is assessment and treatment. look like in an integrated setting. So, in a pediatric primary care setting, it's pretty straightforward, right? We do an assessment, make a diagnosis. Likely there's psychopharm involved with some follow-up. When we're in an integrated setting with behavioral health, we have a unique opportunity to bring in some additional support for evidence-based interventions. And I'll talk through quite a bit today what that looks like. And also just a reminder, we always like to meet the client or the patient where they are. And so that often means that families are um, not ready or willing or interested in a psychopharm approach to treating the ADHD, and that's okay, and that there are interventions that we can provide and support the family in with or without those medication interventions. And my experience shows me that eventually the child gets a little bit older, workload becomes a little bit more difficult, the differences become more and more apparent, and sometimes it's even the child that will speak up, when they're a teenager coming into middle school and might say, I'm really feeling like I'm struggling here and need a little bit extra support. So it's always good when we get the buy-in, but meeting them where they're at. Next slide, please. So quite a few rating scales for ADHD, and pretty much pretty challenging sometimes to determine which is the right one to use. The good news is there is no right one. I think some might be a little bit easier to use than others or more robust than others. But there's multiple rating scales that exist. I would say the most common that I have seen in my practice is Connors or Vanderbilt, with a heavier lean towards the Vanderbilt. And I'll talk about that in a minute. And that is what I use in the pathway. But certainly, if you are already accustomed to a different rating scale, you can substitute the Vanderbilt for another rating scale. And we'll talk through why that is in a minute. Next slide. Thanks. So there's pros and cons to these rating scales, right? Of course, they help us to make an evaluation or a diagnosis. They give us an ability to monitor our patient's progress so we can re-administer the Vanderbilt or the Connors at certain intervals and hopefully see a positive change in the scores. It also gives us a bigger picture about their behavior. So oftentimes we'll see that a patient or a family will come into an office with concerns about hyperactivity or inattentiveness. Particularly, I like the Vanderbilt because it has those uh, additional diagnoses that it's screening for. So it will help us to see, is there actually maybe ODD happening, maybe depression or anxiety that could potentially be leading to a variability in attention or in a hyperactivity. Or is this something else entirely, right? Is this an oppositional child with an ODD or conduct disorder? Rather than the primary diagnosis of ADHD. So we like the rating scales because it gives us a bigger picture and kind of reminds us the right questions to ask in order to really help hone in on what we're dealing with. So yes, helps us rule out behavioral health conditions, as I mentioned. What it doesn't do is it does not give us a complete diagnosis of ADHD. There are some shortcomings, even the Vanderbilt. There's, the initial screener, which we'll talk about in a minute, has a lot of questions about performance in school. And, there's some populations that it's not perfect for, right? If we look at a high IQ, a high achieving child, a gifted child, they may be with untreated ADHD operating for the most part on grade level, especially in the younger years, able to sort of, get by with this extreme level of procrastination or forgetfulness, and still sort of skirting under the radar in terms of performance. And so they won't necessarily be called out on that scale. So it has some shortcomings, but definitely, one of the better tools that we have right now for helping us to screen. And of course, we're all tied to payer models where we're, often required to have some documented evidence prior to a diagnosis. So rating scales can help us in that regard. Next slide. Okay. So as I said, the Vanderbilt is important because it helps us to diagnose and rule out other childhood behavioral health disorders, which I've already said is extremely important, right? As we're, especially if we're talking about prescribing a controlled substance, we really want to make sure that we are actually dealing with ADHD before we get to that. Once we have a diagnosis, we can use the Vanderbilt as a treat to target tool. It helps our clinician, whether it's our behavioral health provider or our pediatric physician, aids in identifying an area to focus on. And also lets us know that the interventions are working, which is fantastic. And it gives us an opportunity to celebrate some improvements. So sometimes in the day to day, it's hard for parents or caregivers or the patient themselves to see the positive changes that are occurring with the intervention, whether it be behavioral health intervention or psychopharm. And so giving a Vanderbilt again at certain intervals, it really can help the patient and family to zoom out and see, actually, we have seen, vast improvement in these areas. And it's self-reported. So, it's wonderful. And the teacher report as well, which is great. So, next slide. So I think we all know that the Vanderbilt is used to evaluate and used as a tool to aid us in the diagnosis of ADHD. It is validated for children 6 to 12. Um, so, it gets a little tricky if we get a teenager who's presenting for the first time. But, through some differential diagnosis and collateral questioning, we can usually determine that the symptoms existed prior to this age, just usually around that middle school age where we tend to see sort of an uptick in patients and families presenting for diagnosis, because now all of a sudden, especially those high achiever or high IQ kids I mentioned before, the gap gets bigger as they get older, and so we start to tend to see that the coping skills that they had maybe learned by themselves prior to that middle school time don't tend to work as well. So um, we sometimes have to get a little bit creative with our screening measures beyond age 12. But did want to call out that it was only validated up to age 12. And we'll go to the next slide. So two assessments. Again, I'm sure everybody in this room is already familiar with the Vanderbilt, but it does consist of 3 subtypes to help us sort of know, are we talking about inattentive, hyperactive, or combined, and does help us screen for ODD, conduct disorder, and anxiety and depression. Again, not meant to be used in isolation and should be accompanied by interviews and other information. Next slide. Perfect. So this is just a sort of snapshot of the rating system for the parent scale. We can go to the next slide. And same for the teacher. Perfect. Okay, so this is the pathway, and I have a couple of other slides that sort of zoom into different sections, but I'm going to take several minutes to sort of talk through this now. So if you can go to the next slide for a minute, and then we'll go back. Perfect. So this is just to zoom in on the actual pathway itself. So what we have here at the very top is the care event. And so the care event is sort of what has brought this patient or this concern to the surface. A couple of different ways, or 3 different ways that might happen. As a provider, you may or may not be routinely screening using something like a PSC 17 or a CBCL. And through that routine screening, he likely had a positive on the attention screen, which could uh, cause a child to enter the ADHD pathway. Uh, More often than not, I think what we see is that the parent and guardian is identifying a concern related to either inattention or hyperactivity. So they're bringing it to your attention at a visit, especially if you're in a practice that is not routinely screening with the PSC 17. Thirdly, you may receive documentation about a diagnosis. So sometimes parents will, for one reason or another, bypass the pediatric provider, and maybe through educational evaluation, uh, a diagnosis of ADHD was given, right? So, students not doing well in school, the teachers are concerned. They're flagging this kid maybe potentially for a 504 or an IEP, and advising the parent to seek educational evaluation or developmental, like neuropsych testing. And so maybe that patient saw a neuropsychologist or some other provider that diagnosed the patient with ADHD. So now they're coming to you in the pediatric office, a pediatric primary care office, with the diagnosis on a piece of paper of ADHD. So what do you do as the provider? This is where it's provider discretion. Do you take that paper at face value and say, okay, let's move forward with the next steps? Or maybe you say, well, I want to do my own evaluation first. Let me see a copy of that Vanderbilt that was completed, or you know, maybe we don't know what led to that diagnosis, so maybe they don't have a copy of it, and then you ask the parent for a Vanderbilt from them and the teacher. This is up to you, the provider's discretion, so it gave you a dotted line here. So the next step is now an identification pathway, right? So how do we identify the patient as sort of continuing on in the pathway? Well, they have a positive Vanderbilt and a confirmed ADHD diagnosis, right? So we've done the Vanderbilt, we've done the parent, we've done the teacher, we've done interviews, we've gotten information, we've asked questions. Now we are fairly certain we have an ADHD diagnosis. So our next steps are to counsel the parent and guardian on their treatment options, right? And so there's several different options here for how what might happen next, right? We, as the pediatric medical providers, may talk to the family about medication. They may say no, right? We're not there yet. With or without medication, we can initiate a collaborative care referral, and so or integrated care, depending upon your setting. And so, yes, a disclaimer: this pathway was developed for collaborative care, but it works in an integrated setting as well. And so we make that referral, we initiate the integrated behavioral health, and now the patient moves into the measurement informed care section of the pathway. And you'll notice that call out. We are working on changing our language from measurement based care to measurement informed care. Um, for several reasons, right? We're not basing all of our care on the measurement alone, but we are using the measurements to help inform and guide our treatment decisions. So it's changing that language. But this is the big call out that I wanted to make, and sort of probably the newest component here is the GIPD. And if you go to the next slide for a moment. Cool. Okay. So the GIPD, and sorry for the pixelated text. This is the best I could get. It even looked like that in the NIH article that I pulled this from. But the Global Impressions of Perceived Difficulty Scale is a scale rating from 1 to 7, 1 being not at all difficult, 7 being extremely difficult. And you can go to the next slide. This is the GIPD. So it's a series of 5 questions, and depending upon who we're asking the question to, is which column we're looking at. And actually, if you go to the next slide for a minute, I cut the physician part out for a second. Sorry, docs, because I wanted to focus on the parent and patient questions, because this is most likely what we'll be asking. And so thinking about the past 7 days, how difficult have your mornings been? So it's a 7-day look back. And that's really helpful because, especially for a kid with ADHD, let alone a parent who's helping support their child, looking back any more than 7 days is usually pretty challenging. And so, first of all, if we have a patient who is taking medication for ADHD, we of course want to check on med adherence first, because that's going to probably impact these questions quite a bit. Okay, so if we can go back a few slides. One more. Okay, yeah, stay here for a second. So we have the GIPD at each ADHD medication follow-up appointment with the PCP. Now, typically, my guess would be, and please chime in, come off mute, tell me in the chat if I'm wrong, but as a pediatric physician, you're seeing your patients for medication follow-up and asking some questions to assess whether or not the intervention is working, right? Do we need to go up on the medication? Do we need to go down on the medication? Do we stay where we're at? Do we need to change course? And the GIPD, I really like it because, again, it gives us a measurement, gives us a number. And so you are able to see over time a shift or a change in those questions rather than getting a qualitative response back. Now, aside from the pediatric visit, if we have integrated care happening, then the behavioral health provider would be using the GIPD monthly. And that, again, is giving us some measurement to help us know if the treatments that we're supporting are working. Um, if we are in collaborative care and we have a psychiatric consultant, they should be consulted for any patient not improving on a GIPD if they've been in care over 30 days. In the absence of a psychiatric consultant or a psychiatric provider, I would kick that back to the primary care provider. No, if you can go one more slide, the other way. Perfect. Okay. So I don't know how easy this is for, I can barely read it and I have a very big monitor, so bear with me. I'll make sure everybody has a link to this. But on the bottom left, we have the collaborative care treatment choices. So in a collaborative care setting, we just tried to help sort of divvy this up a little bit. So I did also call out here that the clinician can opt to use a follow-up Vanderbilt in lieu of the GIPD or in addition to. And that is, and I have that coming up in a few slides, but that's the 18 question. I guess technically it's 23. There's another few questions at the bottom, but the 18 is what we're scoring to help us monitor changes in specific symptoms. Because the downfall of the GIPD, it's great for giving us a very quick uh, number, right? To say, okay, that we're doing better or we're doing worse. But it's not really helping us hone in on the very specific symptoms. And so the follow-up Vanderbilt does help us with that. And so I do still like that tool from a clinical perspective. Um, if the patient is in sort of a symptom monitoring phase, or maybe, we've prescribed meds and we're just sort of keeping an eye on things to see um, if they're getting better or worse, we can also assist here with 504 planning, providing some reasonable accommodations. And I would strongly suggest I have a whole separate presentation on 504 planning. I strongly encourage kids with ADHD to have a 504 plan um, because it provides them with their accommodations that they're legally allowed to have, which is great. Brief check-in. So there's a lot of work that can be done with motivational interviewing, focusing on exploring and resolving ambivalence, especially can be around medication, can also be around just some general behavioral changes. And behavioral activation, again, works really well here. And I again, plug, I do have another hour-long presentation on executive function, executive functioning skills. So I'll just sort of breeze over those today, but that's really where I see, personally, I see a gap in treatment for ADHD in that a lot of there's just not as many providers as I would like to see, both, from a clinical perspective that are well versed in executive functioning and how to provide those supports. And really, I think up until the last couple of years, we've thought about executive functioning only in like an ASD perspective. But our ADHD kids have a ton of deficit typically in their executive functioning ability. And so, let me rephrase, not their ability, but in their executive functioning sort of baseline. And so we can give them the ability through tools and through some education. Now, if they're stable on medication, it's a lot easier to do because they already sort of have the cognitive focus. There's still a lot we can do without meds. So I'm a big proponent for executive function training, both with or without medication. So shifting our view for a second, on the right side here, I did think it was important to call out the primary care HEDIS measures around ADHD and how we in integrated care can help support those HEDIS measures. And so just as a reminder, I sort of called those out here. So patients receiving a follow-up visit with the prescribing provider within 30 days of receiving their first medication are considered in the initiation phase. And then patients who continue taking ADHD medication for 9 months after the initiation phase should be receiving 2 additional follow-ups within those 9 months. Now, most providers, I'm sure, are already doing this, not even to meet HEDIS measures, but just simply from like a DEA perspective. But I did want to call that out here because these measures are, as far as I understand them, applying not just to our ADHD patients on stimulants, but also to those on the non-stimulant medications as well that may not have those same requirements in terms of visits and refills. They do need to remain on the medication for at least 7 months of the 10-month measurement period to be included in the continuation and maintenance phase for the HEDIS measure. And again, this measure only applies to 6 to 12-year-olds. And I also called out some clinical quality outcomes, and I'm not sure that these have been sort of universally accepted. So I'm trying to socialize the idea of these clinical quality outcome measures when it comes to ADHD. So we would like to be monitoring the percentage of patients that are receiving a Vanderbilt assessment, or your assessment of choice if you use a Conners or something else, after scoring positive for attention on a routine screener such as the PSC-17. So if your practice's process is to do a PSC-17 or universally screen for ADHD, then we would like to track how many of those patients are then that are screening positive for attention are getting to the next step. Likely, if we have an integrated care or collaborative care program, we'd like to know the eligible patients that were enrolled after scoring positive. So that's an important measure to track as well. And then our improvement rate, we'd love to see all of our patients who are enrolled in an integrated care program or collaborative care to have a 50% reduction in their GIPD in the first 70 days. And then if we have a psychiatric consultant available, then those patients who did not receive or did not see a 50% reduction, that they did have a psychiatric consultation, or if they're under the care only of the primary care provider, that they were referred back to the primary care provider for follow-up. And I provided some billing codes here. Want to make sure that providers know that if you're doing any behavioral health screens in practice, you do have the ability to bill for that, which now, oh, here it is, the 96127. And you can use that code for each and every measure that you are delivering. So if you do a PSC-17 and a Vanderbilt and a GIPD, right, you can bill for each one of those. And lastly, there's also a call out here if the patient is not enrolled in collaborative care and there is, let's say you're utilizing a state psychiatric, like a mental health access in pediatrics hotline. I know they have different names in different states, but the provider can bill the 99452 for that interprofessional phone assessment. That's another call out I want to know. Okay, next slide. All right, we can keep going. Pausing here, actually, questions about the pathway. Talked faster than I thought I would. So. No? Okay. All right, questions about the GIPD. Okay, then we can keep going. So thanks. So this is the parent follow-up Vanderbilt. And so you can see it's a lot shorter than the full Vanderbilt, right? The full Vanderbilt's 55 questions and it takes a while to fill out. I'll also just kind of add an asterisk here, which is that I have seen, especially on the teacher Vanderbilt, teachers are, very much overloaded these days and sometimes can run through these things very quickly. In a perfect world, that's not happening, but in reality, it is what we're seeing. And I actually saw one patient come with a teacher Vanderbilt that was completely opposite of the parent. Now that happens sometimes, right? Because the parent sees different behaviors, and so if we see the parent is all ADHD and the teachers has none, usually that's a sign that this is an ADHD, but maybe a conduct disorder or some other sort of reactive behavior in the home. But with this scenario that I'm referring to in particular, I knew that wasn't the case. So I'm like, going on here? So I dug a little deeper, reached out to the teacher. Come to find out, they mixed up the ratings, right? So what they thought 0 was all the time and 3 was never. And so we had to redo the teacher. So just, I guess with a little caveat, don't look at it just at face value. We sometimes have to dig a little bit. But anyhow, so this is the follow-up, but you'll see what I mean about performance at the bottom here, right? So if we've got a kid who's, academically doing well, they have a high IQ perhaps, we might not see problems in this area on the Vanderbilt, but that doesn't mean that this isn't a kid with ADHD, and that doesn't mean that this isn't a kid who needs support. Um, and it doesn't mean that this is a kid who couldn't benefit from accommodations in the classroom. And I hear that a lot too. It's like, well, they're getting, they're passing their classes, so they don't need accommodation. And that's not entirely true. Because even with passing their classes or, maybe they're performing on average, but the question is really what is their ability and are they performing to their ability? And if their ability is actually to do much higher than that, then they still could benefit from accommodations to sort of augment the ADHD disability. Okay, next slide. All right, I'm not going to go all into detail here, and we all know the criteria, I'm sure. But this is the DSM-5 criteria for inattentive. So if you're, you know, like me and still in DSM-4 land, need to get out of it. Some changes have been made to the DSM in regards to ADHD. Biggest call out here is that we can diagnose teenagers and adults, and that the symptoms don't necessarily have to have all been present in childhood. We can see them in adolescence. Now, how do we diagnose ADHD in an adolescent when we can't use the Vanderbilt? We get a little bit more creative, right? We just have to start asking some questions to get to these criteria here. Next slide, please. Okay, same for hyperactivity. So again, same thing. We can see these in children 16 years of age or even 17 and older. We just actually, in adolescents and adults, we look for less symptoms. And of course, we want to see these symptoms present for at least 6 months. Next slide. So additional criteria to be met. So some symptoms do have to have been present prior to age 12. Of course, that doesn't mean that you had to have documented them prior to age 12, but that's where the questioning comes into play. Especially, I know, in adults, we definitely see a big uptick in adults seeking ADHD diagnoses right now. There's some controversy around that. Of course, right, in a with the stimulant medication and concerns about abuse, we do have to be you know appropriately skeptical, but at the same time, we're also seeing a lot more literature, information, um, media, other things that are leading adults to say, wait a minute, maybe all these things I've dealt with my whole life that I thought was just me being quirky or me being high energy or me being ditzy and forgetful are actually ADHD. And so they seek treatment for the first time. So this is where we have to sort of dig into some of the questioning around, tell me about your child. Tell me about elementary school, right? What was that like for you? Um, and in women, we see a big difference in symptom presentation often than we do in men. Girls historically in the 90s were not diagnosed with ADHD. And we know now it's because their symptom presentation was different. And so whereas boys would have been sort of bouncing off the walls and hyperactive and class clown and being disruptive, the girls were talkative, impulsive, right? They would blurt out answers without raising their hand. They would talk to a peer incessantly, despite multiple, messages from the teacher not to do so, etc. What did their notes look like, right? Was their handwriting sloppy? Was everything rushed and raced and that sort of thing? Those are the types of questions that we're asking as we're looking to when we're trying to look way back, right? And then of course we don't want these symptoms to be accounted for by another psychiatric disorder. So we look at the PHQ-9 and we see a question about difficulty focusing. Well, that sounds like ADHD. So we really want to make sure we're sussing out, okay, well, is it you're having focusing now all of a sudden? Um, and is that, okay, so let's say we have somebody we know has major depressive disorder. Is your difficulty focusing only happening during your depressive episodes? Instead of your depressive episodes, do you have no problems with focus? That would help us to differentiate. Or maybe they've never had a diagnosis before of depression and they come in with this difficulty focusing. We want to start asking questions. Well, when did this start? And make sure we're not looking at a mood disorder or depression instead. Same thing with the hyperactivity, the fidgety, right? Well, I'm fidgety, I can't sit still. Well, tell me more about what's going through your mind at the time, and you might hear, well, I'm anxious, or I'm stressed, or I'm restless, or whatever, or right, the hyperactivity would be nothing. I've just always been a friend. I've always been a person who just like can't sit still in my seat. And that's always been true, even in adolescence, even in elementary years in grade school. So those are the questions that we're looking for. And then in a kid, we want to just really make sure that these symptoms are not just a manifestation of their ODD or oppositional behavior. And so that one's a little bit harder because we can see a co-occurrence of ODD and ADHD. They're not necessarily exclusive. The question is the inattentiveness, the hyperactivity, a behavior that is an oppositional behavior, right? So we have to get a little bit with the kid into the motive behind it, or is it something that is neurological? That is right. So where it's coming from the ADHD. That question on the Vanderbilt about acts as if driven by a motor, right? If it's like out of their control and they're just like a little wind up toy that's been wound too hard and they're running around everywhere and it's not on purpose, um, that's more likely a hyperactivity rather than an even impulsivity too, right? We're going to see impulsive behavior in mainly in with the hyperactivity, but we see it in both types. Because again, if my attention has wandered over here and then all of a sudden I have to pull my attention back here, I may do something impulsive because I don't have time to think through it, or I'm so worried I'm going to forget what I'm about to do that I don't as a result. Or are we just being a defiant kid? And usually you'll see that the oppositional behavior is happening only in certain settings or with certain people, whereas the ADHD symptoms are happening across the board. We'll see them in school, at home, with peers, with teachers, with adults, sports field, etc. So that's the other main difference there. We can go to the next slide. So families are seeking treatment. Maybe they're coming to you for the first time. Why, right? What's bringing them in? Well, the kids are getting in trouble in school, perhaps. The parents are overwhelmed with either the behavior, the disorganization. They're tired of getting calls from school. The child is struggling academically. The families are stressed. Or maybe the kid is saying, finally, I've had enough. I can't do this anymore. This is too much. Um, why am I not like the other kids, et cetera, et cetera. And then next slide. Go back one. Okay. Some families are reluctant to seek treatment for several reasons. They don't want their parenting criticized. They're concerned. Maybe they've heard it from the in-laws or from the neighbor, can't you just get little Johnny to sit still? And maybe if you XYZ more, you wouldn't have that issue. So they're concerned about that. The medical model, if the child is already prescribed ADHD, so this is talking about seeking behavioral health treatment, so integrated care or collaborative care. If they're already on ADHD meds, they might not see the benefit. Likewise, if they're not interested in medication, then they don't see the reason to bring it up to the pediatrician. They don't know there are options, so that's another reason why families might not be seeking treatment. And next slide. So I talked about executive function. We do have a few minutes, so I'll kind of dive into it just a bit. But this is the cognitive process that organizes thoughts and helps us to make decisions. So we all have executive function, some of us better than others. Individuals with executive dysfunction, they struggle to plan, organize, and complete tasks. They may get overwhelmed by big tasks or misplace things. Their thoughts can wander, which leads to difficulty following multi-step directions. We see this a lot with kids and adults. We'll go to the next slide. So want to make sure that we're all using the same language. ADHD is a neurodivergence. When we talk about neurodivergence, we sometimes think autism or we think about some other neurodivergencies, but ADHD is a neurodivergence as well. It which could explain why the individual with ADHD um, struggles to remember things. Maybe they struggle with time management, right? There's some prefrontal cortex involvement. Or perhaps they struggle with prioritizing tasks, and that might be their frontal lobe or amygdala or the limbic system. Their self-awareness might be impaired. Maybe they don't even realize that they're talking rapidly or speaking out of turn or fidgeting, that sort of thing. So there's lots of different areas of the brain that might be impacting the executive function. And that's why we might see some of these and not others. Next slide. So there's 7 core executive functioning skills, and we might see deficit in some or all of these areas, depending upon the individual. Go to the next slide. Yeah. So quickly to treat, talking about treatment, as I've said already, medication works quickly to reduce the impact of symptoms. CBT can also be used to teach lifelong skills, and this can be with or without medication. And this is where the integrated care model really can come into play here because we can provide skills and teach some of these coping strategies to the children or the patient, also to the parent, in order to provide them with some tools so that in a future where they maybe aren't taking medication, they still have those tools in place and they sort of have that muscle memory for them. Or, they're not prescribed meds at all. So CBT can teach coping skills, coping strategies, helps children to redirect their focus. We do see a 60% co-occurrence of anxiety with children with ADHD. And it's one of those things where we don't know kind of chicken or the egg. Are they anxious because they're worried they're going to forget things? Are they anxious because they know they struggle with executive functioning? Maybe they don't have a word for it or the language to explain it. But we do see a comorbidity of anxiety. And so we do tend to see if we treat the ADHD, the anxiety is treated as well. Um, and it's interesting because, even prescribing a stimulant to treat ADHD, you would think that that stimulant is very activating and that that would cause more anxiety symptoms. It's actually not what we see. We see that when we treat the ADHD, we do see a reduction in the symptoms of anxiety. Okay, next slide. So common thoughts of kids, and I know I'm going off track here with the workflow, so feel free to bring me back if there's some hot questions about it, but I know we had a few extra minutes and I wanted to touch on some of this stuff because I had to sneak it in. But these are some common thoughts that kids with ADHD might have. And so I really think, especially the all black and white thinking, right? I always forget my lunch. I never remember to turn in my assignment. They have some inferiority feelings, though, especially when focusing on another person's strength. And so CBT can really help to sort of reverse some of this thinking. Next slide. And so again, the internal monologue can impact the child's, or the ADHD impacts the child's internal monologue with some of this. Next slide. Okay, just gonna take like 30 seconds to talk about the fundamentals of planning concept. If you're not familiar with it, really cool idea and really works amazing to help kids with ADHD, adults, all people, with executive functioning deficit. So most of us, when we think through a task, we can sort of without even thinking about it, we subconsciously get to the end and work backwards. But because of struggles with visual working memory, people with executive dysfunction struggle with this. And so we teach the skill of starting at the end and coming backwards. So what does done look like? And again, when we struggle with visual working memory, sometimes that's hard for a person with executive dysfunction or ADHD to be able to verbalize or even to visualize. So providing some examples and then working backwards. Okay, what steps do I need to take to finish this? What materials do I need? And then we can start. So it's a few extra steps, but it is a skill that we teach. And eventually these individuals figure it out for themselves and they start to work this way, which is really neat. Next slide. So also just want to make sure we're setting expectations properly with parents. I've had parents come in and say that, um, well, the kid just doesn't get their chores done, and it's frustrating. But then when we talk through, well, what are these chores? They're like way age inappropriate, right? They're just not developmentally appropriate for that kid. And so the first thing I do is just sort of do some parenting education there, if that's the case. But it's also important to teach those skills so that kids can sort of build on their responsibility year over year. Next slide. Perfect. So I talked about ADHD accommodations. I mentioned 504 plan and IEP. An IEP is typically not warranted for ADHD unless there's significant impairment in academic performance and that impairment is significant even with accommodation. Um, there is a multi-step process. It's called the MTSS, multi-tiered systems of support, that are used in schools to get a kid eligible for IEP. But the beautiful thing is that with Section 504 under the IDEA law, a diagnosis of ADHD is enough to warrant a 504. And so they're able and entitled to have those accommodations with their documented impairment as a result of their disability. Next slide. Here's just some examples of some 504 accommodations I have in my references, a very long list, so I won't bore you with reading them for you, but there's some examples here. And next slide. This is an example. If you've never seen a 504 plan before, this is what they look like. So just want to call out that providing accommodations to minimize a neurodevelopmental disorder's impact is the same as providing accommodative lenses to a visually disordered child. Equally as powerful, important, and necessary. And this is coming from OT for ADHD.com. And I do want to call out that there is occupational therapy for students, children, and adults with ADHD, specifically around the area of executive function. You do want to find an occupational therapist that has specific training in this area, but it is an option. Your behavioral health providers can also receive additional training in the areas of executive function to provide these same skills. And then lastly, these are not suggestions. They are federally protected right of students with a 504 plan. So oftentimes schools will um, in error, not not provide the accommodations. And so it's just, this is a place where we as providers can provide some education to the parent. No, they are federally protected rights and they are legally required to have them, even if the teacher doesn't think they need them. Next slide. Some examples of how we might support families who are have an individual in their home with ADHD. Depending upon the age, the younger children benefit really well from a visual schedule. Analog clocks are helpful, dying skill, but helpful versus the digital because you can visually see sort of the spatial awareness of the time that's coming and passing. Some other timers that are also a great resource. And we'll go through to the next slide. So I said visual checklist. Here's an example of what we might use for a sort of standard task. Because again, the multi-step directions can be difficult. And sometimes they might start at step 1 and 2 and then jump to the last step. So we provide a visual or step-by-step checklist. Next slide. And it's always important to have the child's buy-in, if we're talking about a child. And so bringing them in as much as possible, right? Asking them to help develop this checklist for themselves. We know that the more that they have ownership over the process, the more buy-in we get, and the more likely we are to see outcomes. Next. Another example is chunking. And so, we all do this probably when we go to the grocery store. Otherwise, we're running back and forth 15 times to the different aisles. And so this is just sort of a natural way that some people's brains automatically work in sort of chunking things. But for kids, we can take a big project and we can break it down into smaller sections. Next. And so providing children with an example of a finished product can also be helpful as well, because sometimes and not just children, right? Adults too with executive functioning concerns or ADHD may not know, may get hung up on like, what is this supposed to look like when it's done? And because they don't, their variability of attention sometimes can be difficult to sort of hone in on that. So providing a visual example is helpful. All right, keep going. Just some tips on refocusing and redirection. I'll make sure that everybody gets these slides. So um, have additional resources here. If you're not familiar with the Attitudes magazine, it is a fantastic resource. It's a physical magazine. There's also a digital version. It's good for providers. It's good for parents. It's good for adults, kids. I love it. It's fantastic. Children's Hospital of Philadelphia has an executive function clinic that might be a good resource. If you're looking for additional training, the Executive Functioning Success Organization has a 12-week program called Seeing My Time. That is a great resource for clinicians and coaches and providers. And lastly, there's some great podcasts. We'll go to the next slide, please. There we go. All right. I know we're very much close to the end of time, but just wanted to thank everyone for your attention and for listening to me. Would love to entertain any questions or thoughts that anyone on the group has before we wrap up.
Hi, I'm Selena. I'm a child psychiatrist at WashU. Sorry, we all have our cameras off. I think lunchtime, people are stuffing their faces. This has been helpful. One of the things I was thinking about is I was not familiar with the GIPD.
PD.
Yeah, before. And so, the practices that we work with so far, used to the Vanderbilt, that's what we've been using. But obviously it is a lot more questions. I was curious if you've had experience with kind of getting practices to adapt the GIPD, and how that's gone. And then also, your thoughts. I think we have found that parents don't always know what's going on at school, like as much as we'd like them to, or we get teacher Vanderbilts back and the parents are like, I did not know that this is how it was going at school, or and just kind of, how you think about the teacher feedback as you're kind of treating to target. I was curious to hear kind of those two questions.
Sure. Yeah. So this pathway came about because what we were seeing was that despite the Vanderbilt being the gold standard, it's very difficult in practice to use on a monthly basis. And so, what we tried to do was find something that would give us some measurement informed, right? Some measurements that we can then know, is our treatment working? I would say if you're working in a practice that is already doing the Vanderbilt follow-ups on a regular basis and having good success with those, that's why I put that star in there in the pathway that you can use the Vanderbilt follow-up instead. The problem I see is just that most practices do a Vanderbilt one time and then never again. And so then we have nothing other than some anecdotal qualitative feedback to know if what we're doing is working. And so the GIPD gives us, scripted questions with a scoring system so that in lieu of anything else, we get some data back. But if you are the exception to that and you've working with practices who are getting those teacher Vanderbilts back, and are you doing them as a treat to target tool already, it's to keep doing what you're doing, because you're going to get a lot more information out of it. Great question.
Any other questions?
Yeah, Dr. Wells, I see your message about the Vanderbilt teacher. I mean, I struggle to get the initial teacher back. And it's almost always the biggest holdup in us, moving forward with treatment is not getting that teacher Vanderbilt back. But certainly the follow-up. So I would tell my parents that I work with, if you have a parent-teacher conference coming up, that's a great time to do a follow-up. Most schools do them twice a year. So if nothing else, you're at least getting a follow-up twice a year. um it's not ideal, but at least gives us some way to measure how are they doing in school. The other thing I would say is, like, let's start to get some creative with some anecdotal evidence. So bring in a report card. What are the comments on the report card? Because usually there's a comment section, where the teacher, and so do you see a pattern of, well, the comments used to say, Johnny always speaks out of turn and doesn't turn in his work and it's sloppy, and now we're seeing Johnny's made huge strides this year and he's doing so much better. Right. So like that little bit of feedback can be helpful, especially when we're not getting the teacher feedback. I just personally write off the idea of ever getting a teacher follow-up back, because it just doesn't happen. So I will make sure that when this goes out, that there's links to everything. You can read the NIH article on the GIPD. I didn't come up with it. I just actually like spent hours and hours and hours looking and searching, going like, what else is out there that's not 25 questions long that we can try to use, to get some data back, and found the GIPD. So we'll happy to share all that information with you all. And that, unfortunately, the article was actually the only place where I ever have seen it like written. So if somebody here finds like a handout on it, please share it with me. But right now, I'm just copying and pasting out of the article. But thank you so much. And I will put my contact information in the chat. So feel free to reach out with any questions. And so Gina, you have my slides now, so you can get them out with everybody.
Yes,
Thank
we'll
you.
distribute that along with, we'll also send you a link to a quick survey. Please complete
Perfect.
that. It'll always be helpful for us to know how else we can improve. So you'll receive that by the end of the day today. Taj, thank you so much for your time and for this presentation. I'm sure everybody really enjoyed it and it was very informative. And thank you everyone for joining. I'll see you sometime this month. I know we all have scheduled meetings, so we'll see you then. Have a nice day, everybody. Take care.
Thanks.